All right. So everyone, hi. We're almost at 30 people, so we'll get started. Um, I'm a bit under the weather, so I'm not going to be my normal spunky enthusiastic self. Actually, let me just start my video just so people can see me initially. But I'm really, really excited. I think this is Dr. Shira Goldenberg's first time speaking at High Rounds, and we're in for a great treat. I'll let her talk more about what her work is on, but by way of introduction, Dr. Shira Goldenberg is an adjunct assistant professor in the Division of Infectious Diseases and Global Public Health in the Department of Medicine at UC San Diego. She is also an assistant professor in the Faculty of Health Sciences at Simon Fraser University and director of research education at the Center for Gender and Sexual Health Equity in Vancouver, Canada. She leads a program of NIH and Canadian-funded social epidemiology and health disparities research focused on HIV, sexually transmitted infections, and related health outcomes among marginalized women and migrants. She is the PI of a prospective cohort study of HIV, STI, and overdose incidence among marginalized women, and is PI of several ongoing studies examining patterns of healthcare access and sexual and reproductive health outcomes among migrants. Excuse me. So we are so grateful to have Dr. Goldenberg today speak with us. And everyone who's been on this before knows, just use the chat to ask questions. If you want it to be a private one, you can just send it to me. I'll keep an eye on it and only interrupt Dr. Goldenberg for clarifications and save discussion for the end. And with that, I will pass it along to you.
Great. Thanks so much, Dr. Blumenthal. Thank you again for having me. I'm thrilled to be here. And I really appreciate everyone's patience as this is a new audience and group for me to be presenting to. So I'm really looking forward to your ideas and questions closer to the end of the session today. So today I'm going to be talking about my use of social epidemiology research for really policy translation to advance considerations around health equity. And I think this is particularly relevant, I hope, to many of us kind of over the past year where, there are many of us who've been doing sort of equity-oriented work for a long time. But I think COVID has really just kind of sort of amplified the urgency that many folks feel. And I think more the public awareness about the importance of that kind of work and some of the huge gaps that exist in our health system and public health outcomes. And I'm sure I'm to some extent preaching to the choir here. Also just by way of my affiliations, I am an incoming assistant professor as well. I'll be starting next month at the San Diego State University School of Public Health. So hopefully I can have contact with more folks locally through that. So I've been busy, but I'm really looking forward to engaging with folks more locally as I've been primarily based in Canada for the past 5 or 6 years. So just in terms of quick disclosures, I don't have any conflicts of interest to disclose, and the work that I'm presenting today is funded by NIDA, and then several Canadian sources of funding, including our federal funder, the Canadian Institutes of Health Research, as well as provincial funding from the Michael Smith Foundation, local funding from the Vancouver Foundation, and then some of our outreach and more programmatic work that I'll share today is funded by the Public Health Agency of Canada's Community Action Fund. So as I mentioned in my introduction, the COVID-19 pandemic has really shone a light on disparities in healthcare access, social determinants, and structural inequities in health. And my research fundamentally addresses these issues among marginalized and underserved groups. So today I'll be talking a lot about issues experienced by sex workers, women who use drugs, and folks especially with precarious immigration status. I have a few snapshots I just wanted to share on this slide that really highlight some of the pressing issues that the research addresses, including just up here on the top left, for example, the issues around the policing of massage parlors and anti-Asian racism in the wake of the recent Atlanta murder of Asian women. As well, as I'm sure, again, many in this group have been thinking about, HIV and STI prevention, testing, and access to care, particularly in the context of COVID, where there have been some really concerning shifts and disparities that we're continuing to, I think, really learn about and contend with. Health inequities for migrants are a huge focus of my work. I'll speak a lot about this today, again, including some of the impacts we've seen during the COVID-19 pandemic. And then lastly, and this is the part that I feel might be kind of like newest to be discussing in more detail in this setting, but I might be wrong. But I'm going to be connecting the overdose crisis as well to some of these issues, particularly around HIV, and also just health equity at large. So the overdose crisis, as many may be following in the news, I just saw actually something this morning that again wasn't surprising, but that 2020 saw more overdoses in the U.S. nationally than ever before, and the same is for sure true in Canada, to the point where it was featured internationally. It's in our local news every day, but here featured in BBC. And the highest rates of overdose are in BC, and we've definitely seen that changes around sort of the movement of drugs, as well as access to overdose prevention, and just like the isolation and socioeconomic challenges folks have been experiencing during the pandemic, as well as mental health impacts, I all think have been contributors to this and are things we need to be talking more about. Just in terms of like how all these pieces fit together, I wanted to present just a quick overview of my research program and some of the sort of core concepts I'll be talking about today. So as opposed to research that might be more focused on individual behaviors or even biomedical research, my work is really focused on understanding the social and structural factors that underpin health inequities. These include the influences of law and policy, such as criminal justice, public health, immigration policy, for example, population migration and mobility, occupational conditions and housing conditions, and then the influences of racism and discrimination. And one more that's not listed here that's important for sure also is gender. So I really situate this research at the interface of infectious diseases and social epidemiology, but also health services research, and then incorporating social theory to understand like why do these common structural factors impact. I really deliberated in preparing for this talk whether I needed to focus it like just on HIV or just on substance use. If it would be confusing to be bringing all this stuff together. But what we see in our research is all very interconnected because there are many common underlying social and structural contributors to these factors, which then kind of means that we need to be focusing on those structural interventions. And I'll definitely tie it all together, discussing those interventions at the end of the talk. So there are kind of just, three bubbles here where, I've situated sort of the main health outcomes that I'll be discussing today. I include STIs here in the bucket of sexual and reproductive health, but they're often also discussed in the context of HIV. And then kind of how this overlaps with issues around sex worker health and human rights and migrant health and human rights. So I'll start with just a bit of introduction on some of these different themes before going into some of our empirical work. So my work and that of others has shown that disparities in HIV, STIs, and related outcomes are really, really exacerbated amongst the marginalized population. Today, I'm going to talk a lot about the experiences of women sex workers. The cohort that was mentioned earlier today that I oversee right now is a cohort of women sex workers in Vancouver, Canada. And that cohort exists because sex workers face this disproportionate burden of HIV, STIs, and syndemic conditions, including Hep C, overdose violence, and gaps in sexual and reproductive health access. Research has found a pooled odds of HIV that's 10 times higher than the general population of reproductive age amongst sex workers. And in a systematic review that I oversaw in The Lancet in 2015 with colleagues and work since, we've really highlighted the role of structural and social factors. And at this point are kind of looking towards really informing interventions that ameliorate some of these determinants of health. And I would really argue that this research on social and structural factors is complementary to and needed to inform multi-level interventions. So there have been amazing advancements in biomedical HIV prevention, as well as some behavioral interventions. But we consistently see that to really reach the most underserved populations, folks who experience the greatest marginalization, we need additional tools to really bring those technologies to folks who need them the most. And just in terms of some of the gaps in interventions, particularly around substance use, for example, a review found that of 84 evidence-based behavioral CDC HIV interventions, only 3 were specifically designed for substance using women. And there's obviously a significant stigma attributed to substance use in women, especially around maternal and child health. And so, it gets complicated quickly, but there really is a need for more research on these topics to make sure that the approaches that we're taking really serve the needs of the population. The other kind of piece I'm going to be talking to today is really how this interfaces with precarious work. I mentioned earlier that occupational conditions are a focus of my research program. And so women represent half of migrants globally today, yet most HIV and STI research that has focused on migration has tended to focus on male workers or take more of a kind of gender neutral lens. Women are overrepresented in precarious and insecure employment. This includes many sectors folks will be familiar with, such as domestic work or childcare, but also includes sex work. And this often exists because there are structural exclusion from formal labor markets. I'm sure folks are familiar with stories of people who have come from abroad, who may have been like a dentist in their country of origin, but don't meet the credentials locally and simply don't have the income that would be required to spend years kind of studying or preparing for exams or training that would be needed to be able to do those jobs locally. So often folks are doing jobs that they are overqualified for in countries of destination. And really what we know is that there is heterogeneity in migrant sex workers' HIV and STI vulnerabilities and contexts. I'll show some of that in my talk today. When I first started working in this field, there was this kind of feeling that migration was always risky and was very much based, actually, I think I'm going to talk about that in the next slide. So I'll get to that soon. But just to say that this is a lot more nuanced than we previously understood and really shows the need to kind of focus more on the nuances such as like, what are the migration patterns and drivers? In what epidemic context are women situated and how does that contour their risk and healthcare needs? So in terms of how this connects to migrant health, I just kind of led into a little bit. And here I'm using the term migrant as a very broad term that encompasses the broad diversity of people who cross borders to live or work. Canada and the US are among the top migrant receiving nations globally. In the US, 14.4% of the population are immigrants, and this is 20% in Canada. There's been much work around race and ethnicity in health, and certainly around migration and health as well. But I think less work has looked at those intersections between these different aspects of marginalization around how migration also relates to issues around racism, things like health insurance, language barriers. And so there's a real need for research that looks more at changes over time and across the settlement process and between groups. There's been previous work that has examined, for example, the healthy immigrant effect, has found, really big differences in terms of the health status of migrants and the local population or the locally born population for many health issues. But often we don't know enough about kind of when things are happening in people's migration trajectory. Things like big databases typically only include like ethnicity or, whether or not a person was an immigrant. And so some of the work that I'll share with you later has allowed us to really drill down on some of the more nuanced migration categories and compare how, and actually we see a gradient of marginalization and a gradient of disparities in health access and in COVID-19 positivity that sort of increases risk with the more precarious a person's immigration status is. And we've also seen that in other research with the kind of having less time in a country of destination. Lastly, and this is what I almost got into in the last slide, but saved for here, is that mobility has traditionally been conceptualized in epidemiology, and I think for sure in infectious diseases too, historically really as a bridge for ID transmission. That, we know that, for example, HIV sort of diffused, throughout the sub-Saharan African continent and then the world, but especially in sub-Saharan Africa, there's really robust research showing how this diffused across, highways and was really, moved with the population. And sex workers were involved in some of this transmission at, there was a lot of research, for example, examining its diffusion across like truck stops and how that related to sex work. And so what really my research focuses on is the need to kind of like, yes, those are really important findings, but we want to kind of move beyond that also to really think about like, what are the underlying social and structural drivers that contribute to that risk, rather than just thinking about it as kind of the movement of pathogens. And for me, that's been really exciting and rewarding to kind of combine how we think about, social inequities and social theory with epidemiology. So I'll talk a little bit about that today, and I'd love to hear folks' thoughts. So this is just, we don't need to drill down on every aspect of this, but I just wanted to share a little bit of a conceptual framework that has been helpful for me in guiding this program of work. It's not super specific because obviously these details will differ depending on the exact health outcome that you're looking at in a study. but really just this big purple box is where I would say my interests lie in terms of the social inequities and structural processes that underlie health inequities. And I find this helpful because it just breaks it down by level. So at the macro structural level, we're again, back to what I was discussing earlier, things like laws and policies or migration patterns. At the kind of more community, or you could think about this sometimes as the neighborhood level, the socio-spatial and the neighborhood environment are important. Folks' access to community and social supports are also proven to be critical. And then at the micro environment, these are things like, in the context of sex work, where a woman is working, what the risk of violence looks like in those settings, what kinds of safety protections exist, what does the housing environment look like, interactions with law enforcement, and also something I'll talk a lot about today, and I'll try to highlight more in my recommendations given the audience, is that this can also include like the health service delivery environment. So not just kind of individual clinicians, behaviors, but how do we organize services and think about the context in which they're delivered and think about policies in those environments that can create safety and access for folks. So I just want to highlight, there are a few references at the bottom here. This work is adapted from previous frameworks around the social epidemiology of HIV, the risk environment by Tim Rhodes, as well as eco-social theory. And the bolded variables that you see here are really going to be the focus of the research I'm going to talk about the most today. So the majority of the work I wanted to share comes from the Aisha cohort, an evaluation of sex workers' health access, which is a prospective cohort of over 800 women sex workers across Metro Vancouver that's been running since about 2010. And prior to that, there was community-based work that informed the design and sort of setup of the study. Aisha is set up as a platform for the evaluation of structural processes and social inequities on HIV and STI, overdose, and related health outcomes. We do recruitment through time location sampling, and the current eligibility are being either a cisgender or transgender woman, being 14 or older, exchanging sex for money in the last month at baseline, and being HIV seronegative at baseline, since HIV incidence is one of the primary long-term outcomes. I should mention that this is North America's longest standing cohort of sex workers, and includes almost now 12 years of cohort data and multiple exposures. We have semi-annual visits that are either at our study office or in the field, and we do interview questionnaires with HIV, STI, and Hep C serology, treatment, and referral by the project nurse. And we collect a number of novel measures. We link to administrative data on a number of topics. I'll share some findings about that in a little bit. We also do a lot of mapping of neighborhood and workplace environments. And last year, we implemented a COVID-19 supplement, and I'll share some of those preliminary findings later in the talk as well.
Shira,
yes.
Shira,
yes.
It's Jill. I have a quick question. If you can go back to your slide before, or just this last slide. I realize it's a long-standing cohort, but I find the eligibility criteria of exchanging sex just for money in the last month at baseline as somewhat limiting. And, has that been discussed about expanding it, including other things, since we know that money is not the only commodity that people exchange sex for?
Yeah, no, that's a great point. We really hear, and I think you'll see it in the research that I'm going to share, Aisha did start out with kind of more of a focus on survival sex work, and that I think did include a broader definition. I admittedly wasn't involved in the study. Then I joined the team in 2011. But my understanding is that the community felt that it was important to move away from that because there's so much sort of public conflation around like sex work and substance use that people in the community were really feeling like it was important to emphasize more like the occupational and professional aspects of sex work too, that there's a lot of folks for whom they are exchanging sex for money, and that there's been a lot of previous research more around street-based sort of survival sex, but that wasn't exactly the scope of the study that the community was advising us to kind of pursue in terms of some of the impact of the work. And so, this predated me, but that's my understanding.
Thank you.
Yeah, but certainly we do have people exchanging sex for other commodities as well, and that's captured on the questionnaire. So we can restrict or look at that in more detail when that's of interest. Great. So we do extensive community outreach. As I mentioned, this is funded separately through the Public Health Agency of Canada because some of it actually kind of goes beyond the scope of what we would normally do in research, but it's really emerged as crucial to part of our ethical obligation to a community that really doesn't have access to traditional health services. And I know that this kind of may or may not be surprising to folks who kind of have this vision of Canada as being very, accessible in terms of healthcare and inclusive, but there are huge gaps for the populations that we work with. Most of the participants don't have a family doctor, don't feel safe, accessing a lot of routinely offered services. And so while we connect to services to the extent possible, there are many folks who really do, kind of rely on seeing us for sexual health supplies and also clinical care. Again, despite our efforts to not want to be that main source of those resources, we find that often it's really important to just make sure we can do what we can. And so folks are out every week in our outreach van, both to kind of indoor and outdoor settings. And we distribute, over 100,000 condoms a year across various settings and have multilingual outreach as well to massage parlors across the city where folks are primarily Mandarin speaking. The study is also deeply informed by community partnerships. As I mentioned, it's a long-standing project. So we have an advisory board of over 15 organizations that meets annually, and then also partner closely with community on different pieces kind of on a regular basis. It might be connecting around outreach and what needs exist in the community, but also asking for feedback on different pieces of research or advice on directions for the project. And those are really rewarding aspects of the work. In terms of the cohort characteristics, there's just a few key demographics that you can check out here in the pie charts and in some of these visuals where we have a high proportion of both immigrant and also Indigenous women in the study. This is a much higher proportion than the Indigenous population in Canada, which is about 11%. So, because of intergenerational trauma, we do see a huge overrepresentation of Indigenous women in our study and in sex work at large. We can also see in terms of sexual orientation and gender identity that this is a pretty diverse cohort. In terms of immigrants and just some of the kind of racial and ethnic composition of the cohort, for immigrant sex workers, these are primarily folks from China, and then we also do have some Black sex workers as well in the study, and a small number of folks from Latin America. These structural exposures here, I hope, just kind of set the context for some of what I'll describe in a little bit. I'm going to talk a lot today about work environments, as well as violence, policing, and incarceration. So you can just see here in the last 6 months, some of the sort of descriptive data for these concepts. In terms of some of our key health outcomes, there's a fairly low HIV incidence, but we do see a fairly high incidence of acute STIs. Hep C, we've done some work around. And then again, like I mentioned, the overdose is really high, and that's really alarming. And of course, this is just the non-fatal overdoses. We don't, get to follow up, obviously, on otherwise. But we do know that this is likely risen since these data were collected. And I think, probably all of us are contending with the fact that for any observational research during COVID, it's really hard to get accurate measures. And so as the pandemic continues to unfold and we look at our incidence data with a lot of missing visits over the last year, that's really something I don't have all the answers to, but I'm thinking really carefully about. Just as one example of some survival analysis we've done looking at HCV incidence as one of the sort of secondary health outcomes of the cohort, what we've seen in terms of multivariable work of looking at time to HCV infection among those who are negative at baseline is that both acute STIs and non-injection crack use were actually, after adjusting for other factors, the two strongest predictors of HCV seroconversion. And we found this really important because most research in this area has focused on injection-related drugs, but less so on injection-related risks, but less on sexual and drug risks or inhalation. And so this is something that that we published in the International Journal of Infectious Diseases a few years ago. And just here you can see the huge difference in incidence between folks who were also STI seropositive versus those who weren't. And then our HIV and STI incidence analyses are going to be sort of final outcomes of the study. The current funding cycle is to 2025. So we'll be looking at that a little bit later as we have more data to work with. We've done a lot of geographic research with the cohort, as I think I mentioned. This was some geospatial epidemiology work that we've done in collaboration with a postdoctoral fellow who's now a faculty at Washington State, Dr. Afar Amram. And this is really based on conceptual work on the role of sociospatial factors in shaping health. So we really have done a lot of work examining patterns of criminalization, gentrification, and spatial patterning of healthcare access in the cohort. This here is an example of HIV treatment outcomes using linked administrative data on pharmacy refills. So we linked our cohort data. Each participant, well, not each, but participants who consent provide us with their health ID number, which is a unique identifier in the universal healthcare system in BC. So they typically only get one number, and that allows us to link to external databases with consent. So here we looked at ART prescription refill data, not self-report. And we found that at least 67% of the cohort experienced at least one ART interruption of 2 days or more. We found that the median walking time between a person's place of residence and where they picked up their ART was about 14 minutes. That probably seems low compared to folks in San Diego, but for Vancouver, where services and risk tend to be kind of most concentrated in small inner city areas, that was actually farther than I expected, to be honest. And in multivariable analysis, we found that the density of displacement due to policing was associated with ART interruptions. So what we see in this map here is that this red represents the highest we had an index of spatial threats where we looked at a combination of exposure to policing, community violence, harassment, things that basically would make people not want to be in those places. And then we mapped on top of that where folks were experiencing these ART interruptions, and we saw that these things were highly clustered together. So in other words, a lot of the services are located where people are experiencing violence and sort of trying to avoid the police. So it kind of reframes where we might want to locate services. Often I think we try to put them in areas where people are, but in some cases, especially in this neighborhood, I'll talk more about Vancouver's downtown east side later, these can be settings of extensive violence and trauma. They can also be triggering environments for substance use. And so many women talk about actively avoiding these neighborhoods and that being a barrier to their HIV care. So that's something to think about. And I should mention that this was obviously just a sub-study amongst women living with HIV. Aisha began as a study of both HIV seropositive and negative folks. And then later we developed a sister study that's now separate where folks living with HIV are followed. So this was some historical work we did before those changes occurred. In terms of impacts of the work environment, our work has shown that workplace factors greatly shape HIV prevention. For example, we found that reduced access to peer safety in the workplace is associated with inconsistent condom use, that workplace physical and sexual violence are associated with difficulty accessing condoms, but conversely, that having access to supportive third-party managers, for example, an owner or somebody who might be working the front desk at a massage parlor, somebody who might be screening clients, taking their IDs, this was associated with greater access to mobile condom distribution and to greater access to sex worker support and outreach services. And we've used some innovative methods, including multi-level models, to look at the impacts of the workplace level on HIV STI prevention. And what we found here, you can see just kind of in this red box, this is the model where we added venue level variables to the empty model. And then the third model here is where we looked at what is the contribution of venue level factors after also adjusting for individual level factors that were associated with inconsistent condom use. So after adjusting for age, immigration, education, client volume, drug use. And we found that having that social cohesion among workers was protective for inconsistent condom use at the venue level, whereas poorer venue level condom access, this should also be in red, was marginally associated with higher inconsistent condom use. And we're using these same measures of looking at group or venue level factors to also look now at differences between participants nested in different neighborhoods where there are different patterns of policing. So that's something really exciting we're doing in the study right now. I wanted to share as well some examples of how this kind of research can be used to evaluate laws and policies. So in Canada, prostitution, sex work has always been criminalized in different ways. In 2013, Canada's previous prostitution laws were struck down as unconstitutional because they violated sex workers' ability to protect themselves. And so in 2014, new legislation was enacted. However, some research, including what I'll show you, has shown that it actually has perpetuated the same problems, because it's not really rooted in a sort of aim of enhancing sex workers' human rights. It conflates sex work with human trafficking, and essentially doesn't really recognize sex workers' need to safety. And so its purported aims include encouraging victims of violence to report this to police, and protecting those who sell sexual services, and clients are criminalized. So we've published a series of papers evaluating the relationship between this new legislation that it incurred right in the middle of our cohort follow-up period, and various health outcomes of interest. So in terms of just some of the select findings here, in the Canadian Journal of Public Health, we found that almost over 25% of the cohort reported experiencing negative changes following these new laws, including reduced odds of condom negotiation and ability to screen clients, reduced access to clients in places where they could work safely. And we saw disproportionate negative impacts for immigrants, criminalized women, and survivors of violence. And then here in a second paper we published in PLOS 1, we also found that the new laws resulted in reduced access to health services and community and outreach services. And in the American Journal of Public Health, we documented reduced odds of accessing formal workplace supports, which, as I previously mentioned, have been linked to HIV prevention in this group following the new laws. So what did we do with this information? We've worked really hard to translate this, wherever possible, to attempt to influence policy. The work was shared at, various AIDS conferences. We've engaged with media. We produce community and plain language reports, and work closely with partners to share this work and to try to, change public opinion, which is definitely part of this in terms of how policies are designed. But also, we've fed this research into challenges to these laws at both the provincial and federal levels. So our research was previously used in that 2013 decision that overturned Canada's previous laws. And now there's a similar charter challenge happening that's addressing the 2014 laws, where we've been privileged to be involved, where various community partners have been challenging them also as unconstitutional. Some of the other work that we've done with this cohort includes evaluating impacts on the underreporting of gender-based violence. So violence is among the strongest determinants of HIV in this population, and we see very high rates of unreported violence in our cohort. In a recent paper in Health and Human Rights, we used interrupted time series to look at changes in reporting of violence, particularly in regards to the law change, which, as I mentioned previously, had a purported aim of increasing reports of violence to police. We saw a slight uptick, but no significant increase or difference in the trend of reporting violence semi-annually over the course of the study. What we did see, however, were enhanced inequities for immigrants. So we found that almost no immigrants enrolled in the study reported any violence to police post-law reform. And we documented a significant increase in self-reported negative experiences among immigrants, particularly those with precarious status, following the change in laws. And I think I'm going to skip over this. I want to talk about the overdose crisis, but I also want to share some other work. So we'll see if we can go back to that later. I did want to share, however, just some work that we've published that's really shown how we need to look at the intersections between a lot of the criminalization I've discussed already, and how this pertains to racialization and experiences, not only amongst immigrant women, who I've discussed a lot so far in this talk, but also the needs of Indigenous women, who I mentioned are highly overrepresented in our cohort. So building on some of this previous work, I published a recent commentary on the connections between criminalization, gender, and overdose amongst marginalized women. And then, given evidence of severe racism within healthcare and the disproportionate impact of overdoses that we see among Indigenous women in Canada, we explored the interaction between access to addictions care and Indigenous ancestry. And what we found here was that the estimated joint effect of both experiencing police harassment and being of Indigenous ancestry had a greater effect on drug treatment utilization than just these factors alone. So this was an additive interaction that really gives us public health information about which subgroups would benefit the most from an intervention. In other words, that sort of police harassment seems to be far worse in terms of its negative consequences for women of Indigenous ancestry. So while we want to address police harassment broadly speaking, this is also a group that we really need to drill down and provide additional supports for. I think due to the time, I'm going to, I'll just mention really briefly that we've seen, as I mentioned at the beginning of my talk, migration has often been conceptualized in a kind of black and white way in terms of HIV and STI risks. And when I started with this study, it was interesting to see that it was a lot more complex. You can see here that the HIV and STI prevalence in the cohort is much lower for migrant workers compared to Canadian-born women. And so we did find this was associated with many kind of traditional markers of HIV risk or lower odds of those risks. For example, lower odds of injection drug use or inconsistent condom use. But we did see still many gaps in healthcare access for this group, including lower odds of Hep B vaccination. We've seen that sort of migration duration is associated with more unmet health needs, and that those who have a more precarious migration status are more likely to experience condom refusal and to report reduced access to justice. So still, despite the fact that we see lower HIV and STI risks, there are still huge gaps in terms of access to prevention and care for this community. In terms of some preliminary data from our COVID-19 supplement, I just wanted to share a little bit of what we've seen so far. We've asked folks about many experiences during COVID, and here we're focusing just on the self-reported impacts that people described in different domains. And so, here we see huge impacts that are self-reported in terms of concerns around mental health, violence, concerns around housing and food insecurity. In terms of sex work, we see reduced income from in-person sex work, which would be expected. But also negative changes to occupational conditions and reduced access to community services. And then, as I mentioned, with regards to the overdose crisis, that we have seen some real concerns during the pandemic, including reduced access to safer drug supply. This analysis only goes until January. It's possible that this has sort of changed since, because safer supply has been rolled out at a faster pace recently in BC. But regardless, we know that it doesn't meet the full needs of the community still, and so there's a lot more work to be needed here. What else will I say? So I want to share, at least now for a few minutes, some findings from the other study that I mentioned, which pertains to the experiences of immigrant and women and refugee women and their access to health services. And so the IRIS study began as a study that aimed to describe population-based patterns and structural determinants of access to sexual and reproductive health care for migrant women in BC. However, during COVID-19, we received supplementary funding that allowed us to expand the scope of the study to also include people of all genders, and so that we could look specifically also at how this community has experienced the COVID-19 pandemic. And so this is really exciting. It includes linked population level immigration and health system data. We use the same procedures I mentioned earlier in the cohort research, where because of Canada's universal healthcare system in BC, folks are usually assigned a unique health system ID that tracks all experiences in the public health system. And so while this misses a lot of undocumented folks who don't qualify for that health insurance, it does capture the majority of folks. And we still see that these are really important indicators for understanding how precarity, even just around folks with temporary status, affects people's experiences with the system. We're using this as a platform to evaluate changes in immigration and health policy and how this impacts access to care. And it includes the strong focus on community engagement and mixed methods research, where we want to work closely with the community, which includes folks internally within our team as well, to generate hypotheses that are relevant to the population, make sure lived experience is informing the work that we do, and that it's being done in a way that is respectful and ethical in terms of community needs and priorities and avoiding harm. This is the first study that's linked to these immigration and health system data in the province of BC. So it's been a lot of work in terms of figuring out how to do this, but also really exciting and we think fairly groundbreaking in terms of the information that'll be available to public health. So I just wanted to share a few findings in some preliminary work that's forthcoming. This is a manuscript that's just been submitted and is currently, I think, what should be available preprint shortly. And this looks at the number of people who've had a positive COVID-19 test by immigration status. And we've also superimposed here different phases of the pandemic, different pandemic restrictions and changes that have occurred. The main message I want you to take away from this, just because of the time, is really that folks with more temporary status consistently face the greatest risk of COVID-19 with compared to folks who are permanent resident or folks who had citizenship in Canada. And then the other important piece that we've noticed is that there were huge gaps in terms of who was accessing primary care for COVID-19. And so here we see the percent whoever tested positive and the percent who had the COVID-19 primary care visit. And again, we see a huge gradient by precarity of immigration status, where folks who had citizenship were the least likely to test positive, And then like we see this income gradient as well, with folks who are lowest socioeconomic status being, more likely in each category to test positive for COVID-19. And then folks with temporary status, here experiencing the greatest percent positive cases, but had the lowest percent of access to COVID-19 primary care. So there's a clear disconnect between people's need versus access to care. And this is something we're focusing on in our work and our policy work moving forward. We've also had a parallel program of qualitative research that's complemented this, both with regards to COVID-19, but also speaking with folks about their experiences of sexual and reproductive health care. In terms of experiences with COVID-19, these are just some of the key themes that we've identified in the data so far around shifts in health service delivery and the gaps folks have faced. Virtual care has been appreciated by some in terms of its convenience, but doesn't work for all. And that there were also challenges with regards to in-person healthcare experiences, feeling really isolated, or issues, for example, around a lack of sufficient translation for folks for whom English is not a first language. Huge unmet need for mental health support, and then really severe concerns for folks who are living with precarious immigration status, for example, those who are undocumented and who didn't have health insurance. As one farm worker put it, there was a lot of support from the government, but in reality, it was only for those people who have status. So folks are feeling really left behind. At some points, the government had rhetoric about testing and vaccination continue to being available to everyone, but the systems still don't reflect that, because one of the first things that people are always asked for when they register, for example, is their healthcare ID number, which many folks don't have. So there have been important grassroots efforts to combat this, but it continues to be a challenge. So in terms of where we go from here, I wanted to highlight some of the interventions that are indicated by this program of research in terms of advancing health equity for marginalized women and migrants. I would just say overall that targeted efforts are needed to improve health and address social inequities and gaps in services faced by marginalized and underserved groups. I've organized these according to the conceptual framework I presented earlier, and I'm focusing on the top 3 categories, really the structural ones, because I know likely folks are more familiar with some of those biomedical and behavioral interventions. At the macro structural level, it's really important to essentially remove punitive laws and policies. It sounds like very simple, but obviously this takes a long time and is very much shaped by politics. So it requires a lot of patience, I've found, but it'll be interesting to follow current charter challenge on sex work in Canada. And there have been efforts, for example, in Canada as well by, again, grassroots organizations who've been quite effective actually in advocating for immigration reform. And they were effective at the federal minister of immigration eventually agreeing to offer permanent residence for some folks who were in precarious status during COVID-19. So did show that kind of some of those advocacy pressures can change policy and already have been. And so there's a hope for more. In Canada, there's definitely a movement for healthcare for all, where sort of how universal healthcare unfolds and is administered is up to the provinces. And so some have done better than others. And I would say British Columbia is falling extremely short in comparison to, I think, what people feel the values of that province are. And so there really needs to be movement on this. Access without fear policies are also important, where things like immigration status or health insurance simply ideally wouldn't be asked at the point of care, because participants have described this as like a button asking to be sent home, that they avoid the hospital, they avoid healthcare, because of these concerns. At the community level, community mobilization, peer outreach, thinking about the location of services in accessible areas and neighborhoods, so important. St. James Infirmary here is just one example I've highlighted as an incredible peer-driven organization that provides accessible occupational health and safety support, including the whole spectrum of sexually transmitted and bloodborne infection care, testing and prevention for sex workers of all genders. So definitely check that out if folks are curious about what a best practice might look like. And then at the micro environment, which can include the health service delivery level, this can include things like municipal non-enforcement policies where, for example, sanctuary policies, even in California, many cities where municipalities or different organizations or institutions have agreed sort of not to collaborate with immigration. Tailored and integrated care, as we've seen, like some of the issues around HIV, Hep C, STIs, addictions care are really closely sort of linked. and affect many of the same folks. And many folks feel that just having to go to all sorts of different places for different things doesn't always work for them. And so thinking about how we can integrate that in a non-stigmatizing way is so important. Trauma-informed care, thinking about safety within the work environment, multilingual and culturally tailored services, and then self-care interventions like self-testing are all things that, again, we're thinking about in our work. In terms of some of our knowledge mobilization, we've worked to kind of translate this work to policymakers at all levels, both internationally as well as federally. This research has fed into practice guidelines with all of these organizations, which has been really exciting for us. And then in terms of the community, we're regularly having workshops. We've been doing, videos and Zoom and all sorts of creative things this past year to try to get findings back to the community. We have, community advisory boards that shape and direct all of the projects that I mentioned. And then we have this recent open access book for folks who are interested on sex work, health, and human rights that just came out from Springer 2 months ago. And this was very much, again, like sort of targeted at community audiences. I think it's definitely relevant and readable for clinicians as well, but we also made it open access so that, sex worker organizations around the world could download it and use it as well. In terms of COVID-19, we've done a lot of knowledge mobilization as well through commentaries and op-eds, both around sex work and immigration. And many of these have been influential in kind of opening up some discussion on things that otherwise kind of weren't perceived as the highest priorities earlier in the pandemic. And so this has been a way that we've really, to be honest, also channeled some of our frustration into, concrete action within our communities. I just want to acknowledge before we open it up for questions, how grateful we are to all the participants in this research for their expertise and contributions. This is really work that's such a team-based effort. And so all of the staff and trainees who contribute to the research, our team of investigators and collaborators, and all of the community partners and funders that support the work. So thanks so much, everyone, and really looking forward to questions and comments. Now I can see everybody.
Oh, yeah. Of course, you're only looking at me right now, and I don't think you want to look at me so much right now. That was really an unbelievable talk. I'm still taking a lot of it in. I have a question or two, but I'd like to open it up to the group. Nothing came through in the chat specifically, so I'm just going to be quiet for 30 seconds and see if someone would like to ask a question or put something into the chat. I don't know if it's one of these mornings or you just answered everything so well. This is when, for me, being in New York, it's hard. I'm like, no one's saying anything. All right, I'll say something. I do have a question, though, and hopefully others are gathering their thoughts. You brought up a lot about HIV prevention, but not specifically pre-exposure prophylaxis and yeah, specific biomedical modalities that we now have. In the very limited work I've done and what I know of what's going on in the United States, really in cisgender women, it seems like uptake of PrEP in those groups, particularly in individuals who engage in sex work, has been very low. What do things look like in Vancouver, and what efforts have been made to in that arena? Maybe that's a really big question, but very curious about what PrEP is looking like in that particular population.
Thanks so much. No, it is a great question, and I'm going to do my best to answer it. So there are a few things. Number one is that I think BC has so much been a site of like treatment as prevention. As you probably know, this is sort of one of the, I think, early contexts in which that was really established, and just so effective at a population level. So I think because of that, I think the rollout of PrEP was slower and has been less than in other contexts. In terms of sex work in our community, it's a bit complicated, I'll be honest. I think this low uptake you're describing, if I had to guess, and we're not asking about it now for some of these reasons, but we probably should figure out a way to do so. It is because there is this legacy of coercion around HIV care and HIV prevention and sex work, that sex workers have been historically treated as vectors of disease. And there are many policies in many countries that actually continue where, for example, like in Guatemala until 2013, you could do sex work in certain venues, but only if you had, and in many parts of Mexico, this is still true, like a health card that shows that you've been tested, that you don't have HIV, that you don't have STIs. It has to happen every 2 weeks. And in many contexts, the police are involved in enforcing that. And it has become a system of oppression and extortion. We may see higher testing rates, but they might not reflect people's lived experiences of harm. And so I think, because of that legacy and these kind of like mandatory testing and all sorts of things that have happened, I think there's been a real concern around PrEP not becoming another one of those things. And there have been like community meetings and mobilization around this in the Canadian context where there's just been, I think, to be honest, like some skepticism and concern. And just as a researcher, then I've been really careful to not feel like I'm kind of pushing that. We sort of want to make sure the community is on board before pursuing that too much. And so it hasn't been identified as a community priority in our research so far, but it is part of our toolkit. And I think it is something for us to think about, starting to at least have an understanding of what uptake looks like right now. Because truthfully, I don't know in detail, but I agree. I think it's very low in our context.
Thanks, Shira. I can read the question from Dr. McCutcheon. What joint comparative studies with our UCSD group working at the US-Mexican border do you anticipate will be most valuable? I'm sure you've thought about
I love this question. I love this question. And my Spanish is rusty. I'm really excited now that I'm coming back to SDSU to be able to do more work locally. Yeah, so I did my PhD in the joint doctoral program between UCSD and SDSU in public health and the global health track. And so I spent many years, I actually see a few of my old colleagues on the call, so hello to all of you. And I worked in Tijuana and then later also at the southern border between Mexico and Guatemala on similar issues around migration, women's sexual labor, and HIV and STI prevention and gender-based violence. And so I found that work so valuable, and it really kind of did launch me into this area of work. And so I'm still learning, to be honest, about what folks are doing now and kind of what the needs are in the community. But I have also been leading a field course for the past few years that was bringing Canadian students to the border. It was part of my work still with UCSD and bringing them together with a small group of UCSD students where we spent time on both the San Diego side of the border as well as in Tijuana, really learning about migrant health, and especially like from a grassroots perspective of what community organizations are doing. And, especially around like just what's been happening at the border here for the last 3 or 4 years in terms of the migrant caravans and the asylum seekers and all of the, kind of grave human rights violations at the border. Like that's something that's really close to my heart in terms of understanding the impacts of like family separations and just trying to see what the policy changes will look like now with the Biden administration. I think that's something I'm really interested in pursuing to see if there's a way that I can come up with a feasible grant proposal. I think is something that I would really like to do, and that I've spoken with local partners who do a lot of the like legal advocacy and support for folks who are pretty interested in collaborating. So that's something I've been thinking about. Otherwise, yeah, I'm still trying to learn about what my colleagues are up to, their collaborations with San Isidro Health, and then other projects as well that are looking at HIV prevention, again, where I feel like if, I think the immigration lens is really complicated in terms of making sure we're, again, that folks are feeling safe participating in the research if those are sensitive questions. And so I think I would just say I'm in a very early stage of learning about what the community needs are before jumping into it too much. Oh, another piece I'll just mention while folks are gathering their questions is I'm really interested in bringing this social theory to a lot of the work that's happening here, because I think that that's a contribution that I can make. Like I'm really interested more in applying syndemic theory, understanding these sort of intertwining epidemics and how we intervene, especially thinking about the social determinants of health that are common to them. So it might be like some kind of intervention, even at some point that's maybe focused a bit more on syndemics around like HIV, Hep C, and addictions or sexual health care. So those are pieces that I'm thinking about too. Those are great questions. And the prep work here has been very interesting, Jill. So I'm excited to learn more about what that looks like in the US and maybe what I can learn from that and consider bringing back to some of the Canadian collaborators and colleagues.
But I think the point that you're making is such an important one, that it may be a bit of a legacy, or that history sort of remains, and why there's been a lot of resistance. I think and it sounds like you have a great network. I think for us, it's still building out that network and finding where people are. We don't have or at least not on the US side, like a cohort of individuals in this, where we can really get that insider perspective, or I mean even just basic studies on. It's been very challenging, I think, to tap into overall. So I mean, even just what you've accomplished in Vancouver, and the inroads that have been made is enormous and really, awe-inspiring. Oh, we have another. Okay, and how do Vancouver and San Diego differ with regard to your areas of interest?
Yeah, that's such a good question. Yeah, it's such a big question because they are so different. I think for me, one of the biggest differences around and maybe this is just something I need to learn because it might be more present in San Diego. I'm just not tapped into the network as much, but is really around the community mobilization around harm reduction, especially that just Vancouver is a very progressive setting for that kind of work. And so I come with all those expectations, and I feel like sometimes here I'm just speaking a different language, and so I think I'm still learning about what that looks like in San Diego, what those movements are, where I can contribute. I feel like in Mexico too, where I really do want to be doing, cross-border work. I feel that that's even more challenging politically, but that there's really important work happening. Someone here has sent me some information about a local partner in Tijuana. I know there is great work happening at the grassroots level, but they often need to circumvent the government, to be honest, to kind of get that work done. And so I think for me that's a challenge, but I'm so inspired by the community partners that we work with who still find ways to pursue this kind of, honestly, this human rights work that's so much needed despite all of the obstacles in the political environment. And so I think that's going to be a challenge for me, but one that I'm looking forward to learning more about. And otherwise, I think another difference is around the data sources too, that I'm so excited about this administrative data work that we've been doing. I don't know if I spent enough time on it, but the immigrant health services work is really exciting in BC. This has never been shown. There have been qualitative studies, there have been some surveys, but there's never been a population study before in BC around the differences that immigrants face in terms of access to healthcare or even health services, just health services need. And so the fact that we're able to do this is so cool. And so I don't know that there are comparable data sources available in California. I know that there are some, but that's another piece that I'd like to learn about more to see if there's any kind of sort of adaptations of that kind of platform that we could make here. But we're just rolling out that work. So I think we'll have a report and all of this stuff released in the next week or two. So it'll be really interesting to see how policymakers pick it up and what they do with it.
That was very well said, Shira. There's definitely a tangible difference between San Diego and Vancouver, but I think things are shifting. And of course, here in this room, you're speaking to, you're preaching to the choir. These are all harm reduction. I mean, I think almost everyone here are harm reductionists, but there are definitely pockets of change, and I'm sure you will get connected to them swiftly. That's really exciting, though, that you're going to be down here now more.
I'm so excited. I'm really looking forward to getting to know everyone.
That's great. And hopefully we'll start to be in person again soon. And I brought that up, I think, last week. We still don't know what that's going to look like exactly, everyone, but we'll keep people informed. It is the top of the hour. So unless someone has a burning question, they can always email Shira or myself if for some reason they can't find her, and I can get it over to her. But Shira, thank you so much for this really enlightening presentation. And I know there'll be future presentations from you and hopefully somewhat more lively conversation. May just be one of those days.
Oh, it's Friday morning and it's been a really hard year and a half, and it's the middle of the summer. So thanks everyone for taking the time. I put my email in the chat. If anybody wants to connect, I'd love to hear from you, learn more about your work. And thank you so much for having me and also leaving things on a positive note. I really appreciate that.
Thank you so much. All right, everyone. We'll see you in a week. Have a good Friday and weekend.